the next session is on radiographic modalities, so we'll cover the imaging for screening as well as diagnostic tests. So the first speaker is Dr. Andrew Callen. He's from the University of Colorado. He's an associate professor of radiology, a neuroradiologist, and the director of the CSF Leaks program there. So welcome, Dr. Callen.
An absolute honor. I was so sorry to miss this last year. Unfortunately, you're going to get a lot of me today, so I apologize for that. Here are my disclosures. So let's jump right in. I'm going to be talking about both MRI of the brain and the spine. Maybe a little bit more of a focus on the brain, because I think that there's a lot to talk about. We're going to talk about the pathophysiology of MRI brain changes, the way that I approach an MRI of the brain, what I look for, and then I think this really interesting concept of the quote-unquote normal brain. What does that mean in the context of a CSF leak? And then we're going to get into MRI of the spine, how it is different from a sort of conventional MRI of the spine, how we can tailor our protocols to optimize detection of a CSF leak. So let's start with an MRI of the brain. So this has been alluded to already, but there are these two co-occurring pathophysiologic mechanisms in the context of a CSF leak. When we have loss of CSF from the craniospinal compartment, we have our brain sag, this so-called loss of buoyancy phenomenon. And then we have that deliquoration of CSF leads to engorgement of blood-filled structures, namely the veins themselves, and related to the Monroe-Kelly doctrine, which was very nicely discussed in our preceding talks. And we have this mnemonic, SEEPS, that a lot of us know, that helps us remember the findings on the MRI of the brain. We have our subdural collections, our thickening or enhancement of the dura or pachymeninges, venous engorgement, pituitary engorgement, and then sag, brain sag, right? But rather than thinking about all of these as presenting either all or none, altogether or not at all, I think that we should think about them in terms of their pathophysiologic mechanisms themselves. So getting back to that Monroe-Kelly and that loss of buoyancy. And what we found is that these findings do tend to sort of cluster together in those two ways. Dural thickening and venous engorgement tend to present together. This was a study we did on our patients with CSF venous fistulas. Features of brain sag tend to present together, but they don't necessarily have to co-occur. Let's look at some examples of that. So on the first row here, patient A, they have horrible brain sag, but really no dural thickening or venous engorgement at all. Patient B here has obvious dural thickening, some venous engorgement as well, but their posterior fossa structures are completely normally positioned, really no brain sag at all. Both of these patients had CSF venous fistulas. And so let's get into each of those two pathophysiologic mechanisms and what exactly we should be looking for on the MRI of the brain. Sometimes these findings are incredibly severe. Look at the patient on the left. That is kind of like the earlier patient I showed you. Horrible brain sag. I don't think any radiologist would miss this or should miss this. But the patient on the right also has a CSF leak. And they have brain sag too. But I wouldn't be surprised if almost every radiologist read this as normal. There's very subtle narrowing of these cistern distances that we'll talk about here. And there's also this very subtle downsloping of the posterior third of the floor of the third ventricle. And so brain sag, again, is not an all or none dramatic or absent phenomenon. And we're going to get into this later when we talk about the normal MRI of the brain. When I'm looking for brain sag, I'm kind of going through this mental checklist. I'm drawing this line, either directly on the screen or in my head, of this sort of incisural line, approximating the tentorial incisura, and saying, does the aqueduct, is it at or above that line, or is it slightly below that line, as shown here? I'll measure the suprasellar distance, the distance between the pituitary gland and the optic chiasm. That is a result of both sag and engorgement of the pituitary gland. Again, I really like that for the floor of the third ventricle, looking to see is it flat or upsloping, or is it slightly downsloping. We can measure our mammalopontine and prepontine distances, which we'll discuss in a little bit. And then, of course, we can look to see are the cerebellar tonsils descending below the foramen magnum. Now, this last point is actually, I think, one of the more confusing ones, and as was alluded to earlier, can lead to significant problems for our patients. But we need to figure out if there is cerebellar tonsillar ectopia or inappropriate displacement of them. Is this a Chiari deformity, or is this intracranial hypotension? And despite the fact that both of these conditions can result in the cerebellar tonsils being below the foramen magnum, they are completely two different pathophysiologic entities. The Chiari deformity is from the skull being too small. Just like this brain is wearing a shirt that's too small, his belly's hanging out of the bottom, the posterior fossa is not contained appropriately within the skull, and the tonsils are displaced, whereas in a leak, the brain is sagging down, resulting in that tonsillar displacement. And you would think this is, okay, well, that makes sense. Why would anyone get them confused? But it happens, unfortunately, a lot. Let's just drive the point home here and look at a patient with a Chiari deformity on screen left, a patient with a leak on screen right. They both have cerebellar tonsillar ectopia, indicated by the red arrow. But look at all those other intervals that we just discussed. The Chiari patient is not sagging. Their posterior fossa structures are normally aligned. The patient with a leak has significant sag, right? And so we can't just look at those cerebellar tonsils, but unfortunately, there's our incisura line. This happens, and here's a patient that we took care of who had a Chiari decompression. She had a persistent headache, but we could see obviously here that she has horrible brain sag. She also has small subdural fluid collections, and so this was not a Chiari, this was a leak, and she was decompressed and did not feel better. She had a CSF venous fistula. We glued this with fibrin glue, and her brain imaging findings reversed, as did her symptoms as well. So please keep that in mind. And let's move on now to the venous engorgement and Monro-Kelly component of these brain imaging findings. There's sort of four main ones to think about. We have this diffuse dural thickening, pachymeningeal thickening. The pachymeninges is a venous-rich structure. We have engorgement of the venous sinuses, subdural collections, effusions or frank hematomas, and then pituitary engorgement as well. Now, this is perhaps the most recognizable finding in a CSF leak, is this diffuse, smooth, symmetric dural thickening. But unfortunately, this is misdiagnosed frequently too. If you see this on an MRI of the brain, the differential diagnosis is a CSF leak, or a CSF leak. And if you ever find a case where it is something else, please show it to me, and I will show you why it is not diffuse, smooth, and symmetric. This patient was referred to us and for suspected pachymeningitis. They wanted a biopsy of the patient's dura. This was not pachymeningitis. This is intracranial hypotension. This patient had a large CSF venous fistula, and you could see after treatment of that fistula, that so-called pachymeningitis reversed. Venous engorgement, I think, is perhaps one of the most challenging things to assess. It can be the only finding present. It can be incredibly subtle. I like to go on a sagittal image, sort of parasagittally at the level of about the globe, and look at in particular the inferior margin of the transverse venous sinus. This is the same patient before and after treatment. You can see that the margin was convex before treatment. It's now concave after treatment. But this is incredibly subtle, and depending on where you look at it, it can be very variable. So, practice this, sort of this deliberate practice on patients who don't have, you're not suspecting a leak. Look at everyone's transverse sinus. What do they look like in other cases? I think that could be very useful. And don't forget that it's not just the dural venous sinuses or just the intracranial venous structures that can engorge. This patient had a large ventral dural tear in the lumbar spine and had this pial vascular engorgement along the pia of the spinal cord. And so it is all of the venous structures that are susceptible to this engorgement, not just the ones in the brain. This is not a dural arteriovenous fistula. This is just vascular engorgement in the context of a CSF leak. Subdural collections can occur, again, another mimic of other things, but in a patient without antecedent trauma, who's not on anticoagulation, presenting with spontaneous subdural collections, you have to think a CSF leak. We think that this venous engorgement results in some sort of damage or increased permeability to those venous structures, leading to those effusions or frank hemorrhage into the subdural compartment. And so please keep that in mind whenever you see this. And when that venous engorgement and stasis happens, we can sometimes have this complication of dural venous sinus thrombosis. This patient here has diffuse dural venous sinus thrombosis, has a large epidural fluid collection in the spine, had a ventral dural tear at T12, and then there's the intraoperative photo of that as well. Pituitary engorgement is incredibly challenging, especially in our younger patients where there's physiologic enlargement of the pituitary gland. It is not a finding that should be looked at in isolation. It should be taken in context of the patient's age, in context of the other findings there. I don't think I've ever seen a case of just isolated pituitary engorgement without some other feature of that Monro-Kelly pathophysiology. You can see this patient here before and after treatment, though, that there is noticeable change in the craniocaudal height of the pituitary gland after treatment. And now, we talked about this Monro-Kelly doctrine. It's so helpful. The brain, this craniospinal compartment is comprised of CSF, brain, and blood, and that's it, right? Nothing else can change. Well, that's actually not true. So this patient here is presenting with years and years of orthostatic headache symptoms. We can see they have very bad brain sag. But what I want you to pay attention to is look at this thickening along the inner table of their calvarium, and look at it on the axial view as well, this so-called layer cake appearance. There's this diffuse calvarial hyperostosis here. There's these very interesting transosseous venous collaterals. We actually had imaging of this patient for many years prior, 7 years prior to presentation. You could see that this bony remodeling was not present 7 years prior. And this calvarial hyperostosis was due to a long-standing CSF venous fistula. So in a way, the skull itself is a part of the Monro-Kelly doctrine, particularly in the chronic period. You know, we think that something, it's sort of hand-wavy, but right, venous congestion, mechanical stress on the dura and intertable can lead to this long-term chronic remodeling of the calvarium, stimulating these periosteal osteoprogenitor cells and leading to bone growth. And this is something similar that we can see, you know, for example, in pediatric patients who are chronically shunted. Over time, they can get calvarial thickening as well. So sort of a way to conceptualize this when you're looking forward or thinking about it. This was alluded to earlier, but unfortunately, some patients are misdiagnosed with lots of things, but including amyotrophic lateral sclerosis. This patient had worsening paresthesias, and we could see that there's, on the spinal imaging, there is an epidural fluid collection ventrally. There's also this, on the very top image of our GRE sequence, which we commonly get on an MRI of the spine, there's this dark signal along the cerebellar folia, and we see that there's actually some myelomalacia, some injury to the spinal cord itself, involving the ventral horns of the gray matter there. And this was not ALS, this is bibrachial amyotrophy. And this is, you know, we think that this occurs because that epidural fluid collection, that leak is, you know, exerting traction on the motor roots and the C5 through T1 motor roots, leading to degeneration, is frequently accompanied by, but doesn't have to be, by the superficial siderosis. That hemosiderin deposition accelerates oxidative stress and damage to the spinal cord itself. So think about that. And you know, these are almost always a ventral dural tear, almost always, not always, but almost always. That CSF is accumulating in the epidural space. There's trauma to that epidural venous plexus, bleeding through that dural defect, and then hemosiderin circulation and deposition on the pia mater. And that siderosis doesn't only have to be in the posterior fossa. It could be supratentorial or even in the spine. This patient has profound infratentorial superficial siderosis, but also has it supratentorially, those arrows pointing there along the sylvian cisterns. They have a large epidural fluid collection on their spine, but they even have chronic layering hemorrhage in the terminal thecal sac too. And this patient had a ventral dural tear. So it doesn't only have to present infratentorially, it can really be anywhere. That blood is circulating throughout that entire compartment. Now, we can't talk about an MRI of the brain without mentioning this Bern score. I think it receives a lot of attention, and I think both patients and providers have a lot of questions about it. This is a scoring system that is a probabilistic scoring system that helps us determine, you know, what is the likelihood that I will find a leak if I do a myelogram. There's 3 major criteria and 3 minor criteria as outlined here. You look for them, these are all things we've talked about, and then you sort of, you know, you add them together and you assign this probability, right? And this was first described with finding a leak on a conventional myelogram, and then was subsequently validated with finding CSF venous fistula as well. And why are we talking about probabilities, right? Aren't we talking about a disease that's either present or absent? Well, the reason that we are is because there's this concept that some percentage of patients with a CSF leak will have a normal MRI of the brain. Look at this patient here. This is a recent patient of mine. They have really no features of SIH that I would have picked up on their MRI at all, not even subtle. They had a very large CSF venous fistula here on the right. This is the patient that I showed earlier, who has that very, very subtle brain sag that is there, but the report was normal, and so thus the patient had a normal MRI of their brain in their chart, as deemed by the radiologist, right? Also had a CSF venous fistula. So how do we, further differentiate these patients? How do we, refine our pretest probability? Well, there's a couple studies that can help us. Dr. Shiving's group did a study where they looked for CSF venous fistulas in patients with an otherwise normal MRI of the brain. When patients had these meningeal diverticula along their spine, they would find fistulas in about 20% of them, but not if they did not have those diverticula. And also more recently, a study that I think is incredibly useful is looking at the optic nerve sheath diameter. And they found that, when these optic nerve sheaths that are sitting in that soft orbital fat containing CSF themselves, when they become narrowed, you will find fistulas in more of these patients than if they are normal or they are distended. We also looked to see, are these migrainous T2 flare hyperintensities in the bifrontal white matter a helpful negative predictor? These are classically described as associated with migraine headache. And we found that when the patient had these migraine dots in their bifrontal white matter and also had a Bern score of 2 or below, this was more specific for us not finding a leak than a Bern score of 2 or below alone. And so I like to think about these sort of quadruple negative orthostatic headache patient, right? So they don't have features of a leak on their brain MRI, no obvious ones that we can see. Bern is less than 2. They have no meningeal diverticula. They have migrainous white matter hyperintensities in their brain. They have normal optic nerve sheaths. I think right now this is as close as we can get to a pretest probability of close to 0 for finding a leak, but obviously we still have a lot more work to do. But we can't talk about normal MRI of the brain without remembering this concept of normalization over time. So this patient in 2018 was laying on the trampoline with her children. They were jumping around. All of a sudden, she developed a horrible orthostatic headache, presented to the ER, had obvious findings of a CSF leak that we all in the audience can see now. She has brain sag. She has dural thickening and probably some small subdural effusions and a large epidural collection ventrally in the spine. She received a non-targeted epidural blood patch, and her symptoms improved a lot, but not all the way. And 5 years later saw us, and her brain MRI looks basically normal now. She's still symptomatic, and she still has an epidural fluid collection. So over time, these findings will normalize. If you have access to early imaging at the onset of symptoms, get it if you can, because it's more likely that you will see it as positive. Here's her leak. She had this ventral dural tear at T2-3. So when we're thinking about a brain MRI protocol, what is a good leak protocol? Honestly, most of the time, a routine MRI brain protocol will be sufficient. It's absolutely critical to have, some sort of sagittal sequence. Ideally, you're getting contrast with this. Having a 3D T1 post-contrast sequence is very useful. Having some sort of susceptibility-weighted imaging, some iron-sensitive sequence is useful to look for that siderosis. And also, adding a coronal T2 fat-suppressed image of the orbits is a very good idea. You can either order a dedicated orbital MRI, or you can just have that sequence added sort of to the end of your exam to look at those optic nerve sheaths as well. So in terms of brain MRI, I want us to think about Monro-Kelly and loss of buoyancy as these separate but can be co-occurring but not necessarily pathophysiologic mechanisms. To remember the masquerades, there are many of them when it comes to neuroimaging in the context of a leak. And if you don't see obvious evidence of a leak, look at other things. Look at the spine. Look at the orbits. Look at the white matter, for example. And don't forget to look at more remote studies, if possible. So let's touch on MRI of the spine. And we have to remember why the spine. Why are we looking in the spine for a CSF leak? Well, we're doing so because in the upright position, there's a gradient of pressure in the craniospinal compartment. The pressure is the highest lower down, and it becomes decreasingly positive as we move up. It's about 0 with respect to atmospheric pressure near the skull base and can be transiently negative with respect to atmospheric pressure in the skull. So in order for there to be spontaneous loss of fluid in the upright position that is causing the patient's headache, it usually has to be in the spine. And in general, we're not doing a conventional CT myelogram. I'll talk about this more in my next talk. In the context of a leak, these myelograms where we just inject dye and sort of wait a long time and then image them quite a bit later, we will identify the presence of an epidural fluid collection, but we won't know where it's coming from. But it turns out we can do an MRI protocol that can very closely approximate, in likely a non-inferior fashion, a conventional CT myelogram in terms of identifying an epidural fluid collection. And that is this 3D T2 fat-suppressed MRI that we call, some people call a non-contrast myelogram. I think there are 3 benefits to this exam over a conventional MRI of the spine and why I think it's important for this disease. So let's talk about them. Number 1, there's these CSF flow artifacts, these little black lines that to any radiologist in the room, you would look at the screen right and see those black lines and you just look through them all day. It doesn't bother you at all. There's no problem in terms of other diagnoses. And our 3D imaging gets rid of those lines, right? And it's not just that we make a prettier image, but it actually can cause diagnostic problems. These are 2 different patients. Look at the T2 stir imaging. We see those little black lines that the red and blue arrows are pointing to, and they both look like epidural fluid collections, but that 3D T2 fat-suppressed image shows us clearly that the patient outlined in red has a fluid collection. The patient on the right does not. So it's very helpful in that respect for getting rid of those artifacts. Also, the presence of these axial fat-suppressed sequences allow us to scrutinize the dorsolateral epidural space for fluid because a normal MRI, conventional MRI of the spine, typically has a non-fat suppressed T2 image. So look at this on screen left. Both fat and fluid are bright. And so I can't tell on screen left if that's just asymmetric dorsal epidural fat or if that's fluid, but the presence of those axial images really, really helps me. And these 3D images you can just reformat into that axial plane, which is very, very helpful. I also like to use these when I troubleshoot my dynamic myelography. Frequently, we see these little linear densities out in the foramen. We're looking, is that a fistula? It could perhaps be a fistula. Here's 2 patients with these sort of little contrast lines out there in the foramen. But then I just pull up the MRI next to it on both of them, and I say, oh, look, the patient on the left has this little boot-shaped meningeal diverticulum. Contrast is just layering in the dependent portion of that. That's not a fistula. But the patient on the right has this bilobed meningeal diverticulum with this linear structure coming off its apex. That's more consistent with a fistula. And then finally, having very thin slices is helpful for finding subtle dural abnormalities, for example, little tiny pseudomeningocele or blebs. This patient had a remote labor epidural and has this tiny little bleb that you can see there on that 3D T2 fat-suppressed image on the sagittal reformat. And there it is on the myelogram, and there it is intraoperatively as well. And really, if you're looking for these on a conventional sort of T2 stir sagittal sequence, like on this patient here who had an intrathecal catheter at L1, L2, it was removed and the patient had orthostatic headaches. I mean, looking at that stir, I have a hard time pointing to the finding there or seeing that at all. But I think that we could agree that the image on the right, it's a little bit more conspicuous, that little outpouching there of the dura, that tiny little pseudomeningocele or bleb is much more easily seen. So what is a good spine MRI protocol? Again, multiplanar T2 fat suppressed imaging. That's basically what you want. What we do at our institution is we get a 3D T2 acquisitions of the cervical, thoracic, and lumbar spine. We supplement those with some sagittal T2 stir and T1 images. We don't routinely get contrast on our spine MRI. I find that having a T1 is just sufficient for differentiating venous engorgement from an epidural fluid collection. And that's basically what we do. So with that, I'll say thank you, and I'll see you 2 more times later.